Admission forms are prepared for any patient that's coming into the hospital for an anesthetic procedure or surgery. These are very important because they confirm the signalment of your patient, the name, your client's name. There's a spot as well to designate exactly what procedure we're doing, so there's no mix-up there. We can document their weight, and there's also a brief medical history status there on the form. That's very important too, because when checking in, the technician needs to confirm those things, because that's going to change their anesthetic protocol. So we need to make sure that's correct, make sure they have no history of allergies, any medical alerts, anything like that. So the signalment of our selected patient here, her name is Maisie. She is a Yorkie Pomeranian mix. She's 3 years old and she's a female, and she is spayed, and she's a canine. She also has no known medical problems that are known prior or noted in her medical record, but we will be doing a physical exam on her later, so we can confirm that as well. Our patient's medical records can be viewed on the computer. We have digital medical records here. So when we pull up our patient, we pull them up in our practice management software called InforMed. We go to their medical records tab, and then we can hit this all button, and that allows us to view anything that we have done here in the hospital, anything that we've had administered, any soaps, all history is here. Anytime we first see a patient, we ask that they bring previous medical records, and we can scan those in and put them in their medical record on the computer as well. To view those, we go to our link tab. In this case, we have a previous record from veterinary specialist over in Louisville, so we could pull that up and take a look. So a couple more forms we have for surgery check-ins. We first start with going over an estimate. It outlines exactly what procedures we're doing and services that are included. This is an example of a dental cleaning, shows the IV catheter, fluids, an optional item called OraVet. So it allows us to break down that with the client, make sure the cost is okay, and then there is a spot at the bottom for them to sign and okay those things and leave us contact numbers. Next, we go over a surgery consent form. So this again repeats the exact procedure that we're doing at the top, and then allows the client to either accept or decline additional services. So they can accept or decline lab work, pain medication, surgical laser, therapy laser, biopsy, microchip, all that is on here that we go over. There's also a spot to accept the e-collar. And then next we go over a section on whether a client would like us to contact them in case we were to find anything else during the procedure, or what they would like us to do if we can't contact them. Some additional notes, and at the bottom there's a section where they okay doing CPR in the event that anything happens under anesthesia. Again, we have them sign at the bottom and leave contact numbers. So in most cases or places, it's illegal to perform a surgery without getting this consent. So the surgery consent form is very important. So when we're going over these estimate and the surgery consent form, this is when we're also fully discussing with our client the process of the procedure. So in this case, it's this patient's coming in for a dental cleaning. So I would be telling the client exactly what that entails. I would say that is taking full mouth radiographs of the teeth, making sure there's nothing under the gum line that makes teeth need to be extracted. Tell them that we scale the teeth, polish the teeth as well. If there are extractions, we take post radiographs afterwards, and then we let them know that in the procedure we always have an IV catheter as a direct line to their veins in case anything were to happen. We have fluids running during the procedure to help keep blood pressure up. And then again, as I mentioned previously, we go over ways that they can help keep teeth clean, such as the OraVet and things like that. And we ask if they have any questions, and just kind of detail the procedure as best we can. Our case card is actually the same form as our admission form. This allows us again to ensure that there is no mix-up between patients. We know exactly what they're here for, and we just clip this form to their kennel. One additional thing to note on these forms is that there is a spot for a picture as well. When the pets come in, we take their picture, import that into their medical record, and that stays on their admission form and their cage card. So again, there's no mix-up with patients. For lab work forms, we do those a little bit differently. We do also have a lab tab. So any lab work that we have sent out or done in-house is going to show up here. If we're ordering lab work to the laboratory, we send lab work to Antech. We create a new lab here. And you select your test. And that pulls up our lab request form. This can be sent with the blood work. And then when the results come back, they'll be imported into this lab work tab. So we can view any blood work there. Another example for our in-house lab, say we needed to do a pack cell volume before the procedure. The way those forms get pulled up is by putting it on the invoice. And our lab work form pops up here. We fill in our results. And once that is saved, it automatically comes to our lab tab. So that way we can view any lab work that's been done previously or done the day of. So this is an example of an anesthesia form. This allows us to enter our databases for the physical exam. It allows us to put the anesthetics we used, the amounts that we used, and then allows for our values during the procedure when we're monitoring. We can put all of those values in here as well. And there's a spot for the doctor to make their notes too. So this form actually is on our computer as well. It saves into the medical record. And that would, we can, when we're in surgery, we can pull this up and be inputting our monitoring values while it's happening, and then save that to their medical record. So this is an example of a discharge form. It has home care instructions. We do this for any patient that is going home after a surgical procedure. This is an example of discharge instructions after a dental cleaning. So it discusses that there may be a small amount of sneezing or bleeding. It goes over when to start their medications, how much food to offer. We usually say withholding food for a little while before they go home, offering about half for that evening, and then they can resume normal feeding the next day as long as everything is going okay. This has a spot for us to write exactly what they should feed. For example, if there have been extractions, they should be doing canned food, something like that. It also designates when they need to come back for a recheck, so we can make sure everything's still looking good. And then in some cases it will also have other things to look for at the bottom. For example, if it were a discharge form for a spay or neuter, we would be saying monitor for licking the incision, making sure they have the e-collar on. If they're having any vomiting, diarrhea, lethargy, to give us a call and let us know. We want to know about those things, so that would be on the discharge form as well. And then additionally, it would go over medication. So if we send home pain medication, such as Rimadyl, we would want to know if that pet, again, is lethargic, vomiting, diarrhea, any dark stool or blood in the stool. We would want to know that right away. For restraint for the cephalic vein, you're going to want to make sure you have one arm under the jaw to control the head. You have your hand kind of behind the ears, so they can't come back and they can't bite whoever is drawing. And your other hand is going to be holding their leg. You're going to roll the vein with your thumb and then also hold behind the elbow so they can't yank their leg back. And that's going to hold off that cephalic vein. For jugular draws, they can be standing or sitting, whatever's easiest. And you're going to be holding, again, under the jaw, keeping the head up. So the restrainer has access to the jugular vein, and they'll be holding off that way. But you want to make sure that you have control of the head, and you're keeping your arm, your elbow close to their body, so you have control of their body as well. For the lateral saphenous vein, you're going to be holding off at the leg. You can have your thumb above the stifle, and the rest of your fingers holding off on the back side of the leg, and that's going to hold the hold off for the saphenous vein here. If he were in right lateral, you could come from the top as well and hold this way too. To take a patient in and out of its kennel, you want to make sure you're practicing kind of low stress handling techniques, so you don't want to come at them directly at front. You can come kind of at the side. You want to make sure their leash is around the neck before they're out, so you have control of your patient. So to demonstrate, this is Miss Lexi. I'm going to kind of come in at the side, good girl, get her leash on, and then bring her out of her kennel. We can now do bare feet, an exam, whatever we need, and then you want to just kind of walk them back in. Good girl, once you're done, you can remove the lead. So this is an example of taking a smaller patient out of a kennel like I was talking about. These you want to make sure you're not kind of swinging the door wide open and your patient's going to fall out. You want to make sure you have control of your patient before you open the door. And you want to make sure you're supporting their whole body, taking them out. I've got a hand under his chest and under the abdomen. So we can now do what we need, and to return, I'm going to do the same thing. Make sure fully supporting his body and that he is staying in the kennel as I shut the door, and then can latch the kennel. To place the muzzle on a patient, you're going to want to be putting that on in one swift, smooth motion. If your dog is nervous, it's going to be better to come from the side or from behind. So we're going to go ahead and apply a muzzle. Again, you're going to use one swift motion. You're going to hold the muzzle firm and quickly latch the strap behind and under the ears. And you want it to be tight enough where they can't paw and get the muzzle off. You want to make sure they can't open their mouth and bite. So you want to make sure it's the appropriate size. You want to make sure it can't slide off or anything like that. I'm going to demonstrate how to place an e-collar on a pet. Our e-collars, everyone's a little bit different, but ours kind of fold around and they hook there. And then they have loops that also hook around in the collar where you can, or into the e-collar where you can place a bandana or the patient's collar as well, and it helps to secure it on their neck. But the way to put an e-collar on, you're going to kind of tilt the head up, slide it over their nose and their head, and you want to make sure it's behind their ears. Pull their ears forward, and then you can secure the collar, or you can use a piece of gauze, something like that. You want to make sure it's tight enough that they can't remove it with their front feet or anything like that. And then you want to make sure it's the appropriate size as well. You don't want their nose to extend past the end of the e-collar. For a physical exam on a dog, for the purpose of the video, again, I'm just going to be showing doing a TPR and listening to the heart and the lungs, but we're also would be looking at the eyes, looking in the ears, in the mouth, checking their mucous membrane color, CRT, feeling the abdomen, and then watching their overall behavior and mentation as well, all important parts of a physical exam. First look and feel on Maisie, we know that she's a little bit overweight, so a little bit higher of a body condition score. I'm going to go ahead and take her pulse. So I listen directly behind the point of the elbow to feel the heartbeat. I'm going to want to keep them from panting so you can hear the heartbeat. I'm going to listen for 15 seconds. So her pulse is at 120, and respiration for her is panting. To count the respirations for pets, again, you can listen for 30 seconds, multiply that by 2, or listen for 15 seconds, multiply that by 4. And then lastly, go ahead and take her temperature. these are all important components to know before your patient's going under anesthesia. You want to make sure you have no abnormalities. Is 100.8, so that is normal. So I'm going to take a listen one more time to her heart so that I can listen to the beats themselves, and then take a listen to her lungs, make sure I'm not hearing any abnormal lung sounds like crackles or wheezing. To make sure I don't hear any heart murmurs or any abnormal rhythms. We make sure we listen to all quadrants of the lungs on the left and the right side. So now I can take these values and findings and let the doctor know what we found and make sure we have the appropriate anesthetic protocol for her. So this is Louis. He's here for a neuter today. We're going to do his pre-surgical physical exam and demonstrate how to take the temperature, pulse, and respiration. That's kind of at a minimum for the video and for the purpose of time. If I was doing a full physical exam, I'd also be looking at the ears, the eyes, checking the mouth, the CRT, mucous membrane color, feeling the abdomen, checking the skin, and then also watching what his mentation and behavior is like. But again, just for the video, I'm going to show taking a TPR. So I'm going to first start taking his heart rate. So I listen kind of sternally on a cat. Locate the heart, and I count the heartbeats for 15 seconds.
He did fabulous. No issues, no concerns at all. Okay? You're welcome. You have a great day. Yes. Okay, thank you. But yeah, you can come, or you want to come in about an hour, you think?
So I got 40 beats in 15 seconds. You then multiply that by 4. So his heart rate is 160. And then next I can watch his breathing to take his respiration. I'm going to count how many breaths he takes for 30 seconds and multiply that by 2.
And there's not going to be anybody home with him. You can always leave him here for the day too. It's absolutely fine, and that way we can watch him, post anesthetic too. Oh no! Whoa! What is that? Oh, our phone. It's our phone system. I think so. If you're just going to pick him up just to go straight to work, I think it might be better to wait and let us, because we're here till 7.
All right. So watching kind of just the rise and fall of his chest, we got 30 breaths. So that would be 60 breaths per minute. And then lastly, I'll take his temperature, but I also want to demonstrate kind of ausculting the heart and lungs, not just taking the rate. So what you're listening for, when you're listening to the heart, you want to listen for any abnormalities, abnormal beats, or any murmurs. And then you want to make sure you're listening to each quadrant of the lung to listen for lung sounds. So your lung sounds should be quiet. Abnormal lung sounds would be crackles or wheezing, anything like that. And then lastly, we'll take his temperature. We do this with a well-lubricated thermometer. So temp came to 99.6, so just a little bit on the low end. We will get these results to the doctor. But this morning we evaluated our patients, and their ASA grade are both going to be a 1. They're normal, young, healthy patients. So I'm going to demonstrate a blood draw from the cephalic vein. So I'm going to first spray a little bit of alcohol. And then you can use your thumb to put next to the vein, kind of steady it for you, stabilize that vein. You're going to enter your needle with the bevel up, kind of at a low angle. You may need to readjust if you're not in the vein. There you go. And draw back. As soon as you have your designated amount of blood, you can hold off and bring your needle out. I'll demonstrate how to draw from the jugular vein. Again, I'm going to spray with some alcohol over the vein. I'm going to be holding off with my thumb in the thoracic inlet to hold the vein off. I feel for the vein. I could shave if I needed to, as well to visualize the vein better.
Dr. Hayes, are you going?
And then enter your needle with the bevel up. Draw your blood. Hold off and come out. So to draw from the lateral saphenous vein, I'm going to again spray with some alcohol. Get our needle. And you can use your thumb to stabilize this vein as well. Once you can visualize your vein, know where you're poking, you're going to enter your needle into the vein with your bevel up. One quick poke. Draw your blood. And once you have the designated amount, you're going to hold where your needle is and can come out. So for drawing on the cephalic vein in a cat, Kyla has restraint of the head so they can't bite, and then she is holding the vein off, kind of rolling it outward with her thumb and holding behind the elbow so the leg can't come back. Max just recently had a dental, so he already has some hair shaved where there was a catheter, so I'm not going to need to shave, but I apply a little bit of alcohol. And then I can place my thumb kind of next to the vein and stabilize that cephalic vein there. And then enter. Good boy, good boy. Okay. Okay. Draw back. Once you have enough blood, you can come out. And that's how to draw blood on the cephalic vein of a cat. For the jugular vein on a cat, we extend their head up and kind of pull their feet down, and then shave a little bit of hair where we are going to draw from so we can visualize the vein better. And then spray a little bit of alcohol. And then I hold pressure in the thoracic inlet to hold off the vein. And then we enter the vein with our needle. We need to do some readjusting. And then once we've got blood back and we have enough, we can hold pressure, and we've drawn blood from the jugular. To draw blood on the saphenous vein in a cat, we use the medial saphenous. Kyla has pressure on the top of the leg to hold off on the vein. We place our patient in lateral. I've applied some alcohol here and kind of parted the fur so that I can see the vein, visualize it, and also feel it. So we then enter the vein with our needle. Draw back, and once we have enough blood, Kyla can hold pressure where the needle's at, and I can come out. So at a minimum, we check prior to surgery a CBC, a PCV. total solids, blood glucose, BUN, and ALT. Those are all in our pre-surgical profile. If we were hearing any abnormalities in the heart or the lungs, further diagnostics such as x-rays or an ECG would be a good idea. If your patient was elderly or you had concerns for organ function, you could do further serum chemistries. You could evaluate endocrine values, clotting factors, if you had a patient that was predisposed to something like that. If that was a concern, electrolyte imbalances, you could run those chemistries as well. And then depending on if your pet is sick, you could also do a fecal or a heartworm test if those were warranted too. So those are additional databases. Anesthetic protocol can be more of a standard protocol. For both, we're going to start out with a pain management, pain medication to get ahead of the pain. For the canine, he'll receive Rimadyl, and the feline gets Onsior. And then they both get an antiemetic, which is Cerenia, so helps make sure there's no vomiting, no aspiration, anything like that. And then we give a sedative, IM, a pre-medication, that's dextrometer and torb. That helps to relax the patient, give muscle relaxation, helps them move into a plane of anesthesia more smoothly, and maybe even decrease the amount of maintenance or induction anesthesia that we need. So next we'll give their induction anesthetic will be propofol, and that'll allow us to intubate, and then we'll maintain them on the inhalant anesthetic isoflurane at a good anesthesia level. I'll next demonstrate an example of entering into a controlled substance log. We don't have a paper log here. We log everything through our computer system. But we're essentially putting the same information. So for example, if we had a spay patient here with us and we gave 1 ml of dextrometer as a pre-medication, I would enter the quantity in the computer. It's then going to ask me the quantity we used and the quantity wasted, which in this case is 0. I put that through, and it automatically is going to put the date that we used at. It has our patient information, which is everything you're going to write down in a paper log as well. And in a paper log, you would also be signing your name. And in our computer system, anything we enter, we put in our doctor's name, and it also has our name linked to anything we do here. So essentially has our signature in that product that we invoiced. So the beginning of our anesthetic circuit begins here at our compressed gas supply. So this is our oxygen tank. It is providing the oxygen for the anesthesia system. So we start by turning our oxygen on. We can then read the tank pressure gauge. Allows us to know how full the oxygen tank is, what the pressure is within the tank. It then travels through the pressure reducing valve and into the gas lines. So the pressure reducing valve reduces the pressure from the tank, making it into a manageable pressure into our line. So it then travels through our gas line and out this way. The oxygen then travels through our gas line to the flow meter. The flow meter delineates exactly how much oxygen is being delivered to the patient. So if the flow meter isn't on, no oxygen is going to be delivered to your patient. So the flow meter also further reduces some of the pressure of the oxygen as well. And then near your flow meter, you're going to see an oxygen flush valve. The flush valve bypasses the flow meter and delivers pure oxygen. So you could be using your flush valve to fill a collapsed reservoir bag. You can also use the flush valve to deliver pure oxygen to a critical patient or something like that. So the oxygen then leaves the flow meter. It enters through the inlet port into the vaporizer. This contains your liquid anesthetic that is being converted to a gas. It is then added, a specific amount is added to your carrier gas that is delineated by your valve or your switch on the top here. You can turn how much you want, how much anesthetic you want on. This is isoflurane. After that, it then leaves the vaporizer through the outlet port and travels up our line and then enters the breathing circuit through the fresh gas inlet. The gas then travels through the unidirectional inspiratory valve, which only allows gas to travel one direction. So it comes through that, enters our corrugated tubing, up our tubing and into our endotracheal tube to our patient. And then along the way, it also passes this negative pressure valve that can be opened. That allows room air to enter the system in case there's too much negative pressure that builds up. For example, if your oxygen source was empty or wasn't turned on, then that valve assists there. So when the patient exhales, that gas is then traveling up the corrugated tubing again and enters the unidirectional expiratory valve. So again, the gas is only moving in one direction, and then passes to the carbon dioxide absorber. So this is going to remove the carbon dioxide from that gas before it's returned to the patient. And along that way, it passes by the manometer. This is measuring the pressure that is in the system and subsequently the pressure that's in your patient's lungs. So routinely, you don't really want your pressure to be above 20 centimeters H2O. So that's your manometer there. It also passes along the way the pop-off valve. The pop-off valve allows any excess pressure in the system to be put into the scavenging system so that too much pressure doesn't build up in your breathing circuit. And if there's an occlusion valve by your pop-off valve, you could temporarily close that to keep gas from exiting the system if you needed to give a breath. So then gases that remain in your system will then enter your reservoir bag. That is going to act as a storage for excess gas. It allows us to manually ventilate the patient and also allows us to see their breathing when they're under anesthesia. So your excess gas is going either through your carbon dioxide absorber into your reservoir bag and returned to your patient, or it's exiting the scavenging system, which is this line here. So our system is an active scavenging system, which means that we have a machine that vacuums that gas out of the building. If this was a passive scavenging system, it would be relying on gravity to get that gas down to either an activated charcoal canister or just exited the building. So I did a discussion of our anesthetic machine and our circuit and our active scavenging system. Our machine is a rebreathing system, rebreathing circuit. This would be an example of a non-rebreathing circuit. We use a non-rebreather for small patients. Rebreathing system has less resistance for them. So the oxygen comes through here, the patient breathes out, it goes to the reservoir bag, and then it goes straight to the scavenging system and goes to an absorber. So it does not circle back to the patient. Another way to administer gases to your patient are going to be masks. You can use these for pure oxygen if you have a critical patient, or for anesthetic. You would place their muzzle in the hole of the plastic there. You want to make sure it's a tight seal so you don't get any leaking around the side. It is less efficient, so you will get a little bit, but the masks are there if needed. As a patient you can't get an IV into or something like that. And then lastly, we also have an induction chamber. So this is a way you can induce anesthesia as well. You would open your container. If you had a really aggressive patient that you can't touch, you could put them in your anesthetic chamber. You want to make sure it's fully closed. So it has two valves. You put your corrugated Y tube in one port. That's going to be your exhale gas, or your fresh gas, excuse me, and then the scavenging system goes on your second port, and that will be your exhaled gases will be scavenged out that way. To perform a leak test, you want to make sure you occlude your breathing circuit, your corrugated Y tubing, occlude the end of that, and then occlude your pop-off valve. So on our anesthetic machine, we actually have an attachment that we close, and you have to hold so that we don't forget to reopen the valve. So that's kind of our pop-off valve. Normally it would be here and you would kind of twist open and closed, but we have our attachment. So I've got the end occluded here, our pop-off valve closed. I'm going to press the flush valve to get our manometer to read at 20 centimeters of water, and you want to make sure that is not going to drop faster than 1 centimeter per second, because if you're seeing that, then it's going to indicate that there may be a leak in your system. A leak, you'd want to be checking your bag, making sure everything is attached properly, check your absorber, and make sure everything is tight, and find the source of the leak. So this is our pulse oximeter. This is going to measure the amount, the saturation of oxygen in the blood. This needs to be on kind of a hairless portion, so it can go kind of on the prepuce. I'm going to put it on the tongue, and it uses light to measure the oxygen saturation of the blood, so the SpO2. So this is our esophageal stethoscope. I'm going to demonstrate placement, and this can help us to listen to the heart rate if the sterile field is one that we can't access the thorax normally with our regular stethoscope, so this allows us to maintain listening to the heart rate. We did put some sterile lube on the end of our esophageal stethoscope. Basically, it's just going to slide under your endotracheal tube. And we can then listen to the heart rate. We hook up our ECG leads. So the ECG is measuring the electrical activity of the heart. That's okay. So your white lead goes on the right arm. Your black lead is on the left arm. And then the red lead is on the left leg. And you're going just proximal to the elbows and the stifles. And then you spray those leads with some alcohol to increase conduction. So the endotracheal tube maintains an open airway for your patient and proper delivery of gases, and then also reduces the risk of aspiration when you inflate the cuff. It's chosen by the size of your patient. The end can kind of measure between the nostrils is a good general rule of size, but you also want to make sure you have other sizes readily available, a size up and a size below in case you need to make a switch. To check for leaks, you would submerge this in water and then inflate the cuff, and if you saw any bubbles, then that could indicate that there's a leak. In order to ensure placement, you want your endotracheal tube to go from the tip of the nose to the thoracic inlet and not any further on your patient. So that way you can ensure it's in the right spot, it's not going too far into one of the bronchi, because at that point you're going to notice that you're having a hard time keeping your patient anesthetized. Capnograph. This is monitoring the CO2. It is going to measure the respiratory rate and measure how much carbon dioxide he's inhaling and exhaling. This way we can make sure he's not hypoventilating or hyperventilating. So the capnograph goes between the endotracheal tube and the Y piece between your breathing circuit. And then our blood pressure cuff can be applied. This is an oscillometric blood pressure reader, which means that the machine manually inflates and deflates the cuff. We do have a Doppler as well. but this is easier for surgery procedures. And this can go around the metatarsals. You want your cuff to be about, width to be about 40% of the circumference of the leg. So you wrap that there, and then we can push start on our machine, and it's going to read. During the procedure, we can monitor temperature by using a thermometer probe. So this gets inserted rectally. And ideally, you're taking temperature during the procedure every 15 to 30 minutes and making sure it doesn't drop anywhere concerning.
So this is Sarah. She is my preceptor, and she will be helping me with the tasks in these videos moving forward.
To place a catheter in the cephalic vein, we first shave the area where we want to place our catheter. And remove any of your loose hair. And then we're going to scrub our catheter sites, starting with our aseptic cleaner, chlorhexidine. And follow that with alcohol.
You want to go live in the office?
Hang out there. And we're going to do that 3 times. And I'm just going to dry the back of her leg here because it got a little bit wet with our scrub. And then open our catheter aseptically. We can remove the cap. Make sure we have the bevel up on our catheter. And I can hold the leg stable with my non-dominant hand. I can put my thumb kind of next to the vein to hold that steady as well. And then enter the vein. And you can see the blood flowing back in my catheter there. Make sure that it's flowing okay, and then I can advance the catheter and pull out the stylet. And then place my cap in the end here. And I can now begin taping. So the first tape is sticky side up. To secure the catheter to the arm. Our next piece is sticky side down. Goes under the catheter. And again wraps around the arm. And we can now ensure that the catheter is flushing properly. So I'm going to hook up our fluids and give a little flush. sure we're flowing well here. And we watch above the catheter for any swelling. That could mean that the vein has blown or you're outside the vein and it's flowing well. And then lastly, I'm just going to apply a little bandage, a little bit of vet wrap to that. To start a saphenous catheter, you first want to shave the area of your leg where your saphenous vein is. And then remove any loose hair. And you can next start your scrub. You're going to start with an aseptic cleaner. So we use a Chlorhex scrub. And do that in a circular pattern. And follow with a rinsing agent, which is alcohol. And we're going to do that 3 times. And then next you want to open your catheter aseptically at the end here. Remove your cap. And you want to grab the leg with your non-dominant hand. You can stabilize your vein by placing your thumb parallel to the vein. You're going to enter the needle into the vein through the skin at a low angle. And once you get your flash back, you can advance your catheter and pull your stylet out. Then place your cap. And now you can tape. So your first tape is going to be sticky side up to secure the catheter. And you're going to wrap around the leg. Your second is going to be sticky side down. Again, wrapping around the leg to secure the catheter. And at this point we can apply a catheter cap and then flush the catheter to make sure it's patent. And I just have a little bit of saline in here to flush. And you want to be watching for any swelling above the catheter. If you saw swelling, that could mean you're outside the vein or your vein has blown. So that's flowing fine. And then lastly, we can just apply a little bit of vet wrap to secure our catheter here. So I'm going to demonstrate giving a sub-Q, IM, and IV injections. This is just half an ml of saline. So for the subcutaneous injections, you're going to tent your skin. You can do this above the shoulder blades, kind of all the way down, caudally where you've got extra skin. You're going to pull up on your skin and you're going to insert your needle parallel to the long axis of your tent. And you're going to insert with the needle up. You're going to feel it pop through the skin. You'll pull back on your plunger of your syringe, make sure you're not seeing any blood, and then you can administer. If you had blood come back in your needle hub, you would want to come out and then poke again, because that would mean you're in a vessel. You don't want to give that that way. So secondly, for an IM injection, we can do this on the back leg. You place a hand with your thumb over the femur, which is going to make sure you're going to avoid kind of the sciatic nerve in there, and that leaves a good amount of muscle back here where you can inject. This is different than the sub-Q because you're going to be going more perpendicularly into the muscle. So we're going to kind of poke, pull back on your needle, make sure you're not getting any blood, and then inject. And then lastly, demonstrate the IV route of injection. Demonstrate this on the cephalic vein. So I'm going to spray a little bit of alcohol on the leg. I'm going to hold the leg with my non-dominant hand. Put my thumb parallel to the vein to keep it stabilized. Insert again with the bevel up to enter the vein. Pull back, make sure I've got blood back. Means I'm in the vein, and then I can slowly administer my medication. So this is Dr. Crum. She's doing Louie's procedure today. She's kind of watching what we're doing today. We're going to induce Louie with propofol, do an IV injection. You're going to bolus this to effect. So we're going to start with about half of this at first. Pushing about 3 mLs to start. Take effect, and then we can check his reflexes, make sure this is taking effect how we want. We can check his jaw tone, his blink reflex.
He still needs more.
Give a little bit more. And we're going to give the remaining 3 mLs. The process of intubating, we have an endotracheal tube. We're going to lube the end of that with some sterile lube that we've placed on our paper towel here. And then Sarah is holding the patient's head up so I can visualize the larynx. She's got the neck kind of extended for me. I'm going to use a piece of gauze to pull the tongue up and out so I can visualize the epiglottis there. I'm going to push that down with our tube, push the soft palate back, push the glottis down to, or epiglottis to visualize the glottis, and then gently slide our endotracheal tube down. Using a rotating motion, and then once placed, we do this in sternal. Once placed, we can secure the tube. We can use a lock knot around our tube to secure there.
Okay.
And then you'll bring your strings
Yeah, so I already have
either
appointments scheduled.
around the nose or behind the
That they
head.
have scheduled
I'm going to bring
for
this
us,
behind the
so
head
I'll just do my follow-up.
and tie behind the
Then
ears.
lab work there. Is that,
You
would
can
that be
use
okay?
IV tubing as well. We can now inflate the cuff. We want to make sure our cuff is inflated using our cuff syringe. Pull back about 6 mL of air. Attach that here.
Okay.
And you want to make sure your cuff isn't overinflated or underinflated. You can indicate that by getting a good feel on your cuff indicator here. And then also to check the cuff, you want to listen for leakage around the tube. Not hearing any air. So then we can attach the endotracheal tube to the anesthetic circuit and place him in lateral. One other way to check cuff leakage would be closing your pop-off valve and then squeezing your reservoir bag. You would inflate the cuff until you did not hear any leaking around 20 centimeters H2O. Then you could know that your cuff is fully inflated. Also demonstrate lubing his eyes. We have some artificial tear solution here, so we're just going to go ahead and lube up his eyes for the procedure. So this is another patient. This is a feline neuter. So prior to scrubbing and prepping, we're going to palpate the bladder and express if necessary. So he did have some in his bladder, which I'm expressing now. I don't know if you can see the urine. And this way he won't urinate during the procedure and interrupt our sterile field. I'm going to now demonstrate how to prep the patient for surgery. You're going to start with clipping the hair. You're going to hold your clippers with a pencil grip. The amount of hair you're clipping is really going to depend on what surgery you're doing. So we're doing a neuter and it's possibly crypt orchid, so we're going to go higher up on the abdomen. A good rule of thumb, general rule, would be to do 2 clipper blade widths around your incision area. After shaving, you want to go ahead and vacuum and get all of your loose hair off. Next, we're going to demonstrate how to do the surgical scrub prep. When you're doing all the prep, you want to be wearing a jacket or something covering your scrub so that you can remove that before transfer and not bring any of those contaminants into your surgery suite. So you're going to start your scrub. You're going to do a target pattern. So starting with an aseptic, you're going to start where your proposed incision site is going to be, and you're going to move outward in a circular pattern. You don't want to go back and repeat over any area you've already scrubbed. You follow that with the rinsing agent, is alcohol.
Okay.
Again, starting at the center and moving outward in circles.
I
started out as the 28 call, and there's one thing I learned how we're running with this progress, that's what I was called again.
And we're going to do that 3 times.
I I have nothing under my medical center on the 28th or the 30th for Miss Allen.
Well, weird, because I've got her scheduled as an extra under your correct name.
This is really weird.
And follow the scrub with the alcohol.
I'll take care of her. What line is she on?
She's on line 2.
Okay, then.
Thank you.
And last one.
Do it.
So we can now transfer our patient into the surgery suite and do one final scrub. So after we've clipped and prepped our patient, we remove our jackets so that none of that gets transferred into the surgery suite. And we can now transfer our patient using a sling so that they are supported and we're maintaining our sterile field into the surgery area. We can then secure our patient to the table using these ropes. Place one around each leg. And then we can now do a final scrub, attach all of our monitoring equipment, and begin surgery. So during surgical procedures, it's our job to monitor the patient, check their heart rate, their respiratory rate, and we document all that on our anesthetic forms in the computer. So we always write down the ISO amount we're at, the oxygen level, and then our monitor there gives us our heart rate. It also reads SpO2 and blood pressure on that machine. So I'm going to go ahead and enter those values here. Our ISO currently is at 0.5%. Our oxygen is at 1%. Our heart rate on the monitor shows 161. Our respiration is currently not showing on the machine, so we can also take that manually, which I'll do in just a moment. We check their mucous membranes. So I do that by going under the drape. I don't ever go over the drape without entering the sterile field. So I take a look at her gums, see that they are pink. And I check the capillary refill time, which is less than 2, and then record that here. Our SpO2 is reading at 96, and blood pressure is 150/124. And then if we need to record manually our heart rate or respiratory rate, we could use an esophageal stethoscope or a regular stethoscope, and again, just go under the drape. watch respiratory rate would be the inflation and deflation of our reservoir height. And then lastly, during the procedure, we take our normal monitoring values every 5 minutes, we record those, and every 15 minutes we record their temperature. If your patient has arrested and you confirm that there is no heartbeat and no pulse, you want to immediately start CPR. You want to turn off any anesthetic drug delivery system, whether that be inhalant or a CRI, anything like that. Turn those off and begin chest compressions. So you want your patient in lateral. You want their feet away from the person doing chest compressions, and you want to do compressions with a two-handed technique, and you're going to do those compressions over the widest part of the chest. And you want a rate of 100 to 100 beats per minute. You can alter location depending on the size of the chest, the type of dog. If you have a small cat or a small dog, you can use the one-handed method as well. And then you would want to make sure you're compressing about half the width of the chest and allowing it to re-expand each time. So then you're going to intubate your patient and do manual ventilation. So ideally you want your patient hooked up to 100% oxygen and deliver 10 breaths per minute. But if needed, you can use an ambu bag as well, and this is going to hook up to the endotracheal tube. And you could even deliver room air. You want to give one breath about every 3 to 5 seconds. You also want to make sure that you're rotating the person who is doing chest compressions every 2 minutes. So we've already placed the packs necessary for our procedure in the surgery suite. I've done just a normal hand wash of my hands, so I can then open my gown. Take that out. The outside is not sterile, so I can touch that. And I use the tabs to go ahead and open the gown pack. And then open my glove pack. And now I can start a scrub. So we use a chlorhexidine scrub. Go ahead and get my arms wet. We want to run the water from the fingertip to the elbow. And then we can start scrubbing, starting kind of under the fingernails at the fingertips. And we do a stroke method, so do 10 strokes for each surface. And then you can start with each surface of the finger. You're going to do all 4 surfaces, 10 strokes on each surface. And no matter which method you're using, you should be scrubbing for at least 5 minutes. Side of your hand, the palm, the back of your hand, in between the fingers as well. And then you can move from the wrist down to the elbow. And again, 10 strokes on each surface of the arm. starting at the fingertips. Once you're done scrubbing, you're going to rinse again from your fingertips to the elbows. You want the water to run that direction. And then we dry our hands with a towel. Unfold. Use one side for one hand. And starting at the fingertips, you're going to kind of dry circumferentially down to the elbow. And then that's the other side. You're going to use the opposite end for the other hand. Dry from your fingertips to the elbow. And you can drop the towel. Next you're going to put on the gown. So you can touch the inside of the gown. So you can kind of pick up at the inside of the collar, allow the gown to unfold itself, and put your arms in, but you don't want to let your hands come out the ends of the sleeves, and you'll have an assistant to help close the gown. So now we'll do a closed gloving, so you don't want your hands to come out of your sleeves. You'll start with one glove. Start there, and then with your other sleeve you're going to pull the glove cuff down over the gown cuff, kind of pull them down at the same time. And now you can do the same with the other hand. Put that over. And then pull your glove cuff down over your gown cuff at the same time, pulling both down. So there's also a method where you can place the glove palm to palm, thumb to thumb, and flip over. But this method still, our hands don't come out of our sleeves, and we're doing a closed gloving. And now we are ready to start serving. So after scrubbing in and doing a closed glove and gown, we can then open our instrument pack. You want to be sterile, and you want to try not to cross the sterile field. And this would be the point where you would be counting your instruments and your gauze as well to make sure at the end you have the same number of instruments and gauze. We can then begin to drape the patient. So the first drape is going to be laid closest to you. And then you can move around the sterile field rather than reaching over to place the other side, right? And then you got a cranial drape next. And the caudal drape last. And then attach your towel clamp. And then we can place our drape, our second layer, the top drape. On top. The doctor will cut her opening for the surgery, and now everything under that top drape is not sterile. So this procedure is a canine complete ovarian hysterectomy. In this procedure, we don't actually need to moisten the tissues, but if that were necessary, we could have a sterile bowl in our sterile field at the back of our instrument tray. We could soak some gauze and either drip that over our tissues or blot those tissues to keep them moisturized. To blot tissues, you can use gauze, apply some firm but not excessive pressure, and make sure that you're blotting, you're not wiping, you're just blotting for the doctor. And then you slide your blade onto your scalpel handle, and we'll kind of feel it snap on there. And we can now pass the scalpel to the surgeon. You're going to want to have the blade down, pointed towards you, holding between your thumb and your index finger, and kind of rotate with your palm down and outward. For a hinged forceps, to pass, you want to lock the first ratchet, hold at the box lock with your thumb and index finger. The rings should be facing the floor, and you can pass to the doctor. To pass the thumb forceps to the doctor, you're going to want the forceps end pointed downward. Then you're going to hold the top portion again with your thumb and index finger and keep it stabilized and pass to the doctor. So the responsibility of the surgery technician once they're scrubbed in is to maintain the sterile field, keep track of your instruments, pass instruments to the doctor, and then if you were to accidentally break the sterile field, if you had a puncture in your glove, you would want to immediately leave the sterile field, have an assistant help you change gloves, same with the gown. We want to make sure we stay sterile by keeping our arms above our waist, not turning our backs to the sterile field, not allowing our gown to touch anything or rub up against anything that's not sterile. If the gown also becomes contaminated, you can have an assistant help you change the gown as well. This procedure is a canine neuter.
Do daily, we're supposed to be monitoring them.
He's already been shaved and prepped, and I'm monitoring during procedure. This is a feline spay that I'm monitoring for a doctor. So for cleanup post-surgery, I'm going to first start with cleaning the surgical table. We have a blade on the table, so I'm going to use needle holders to pick that up for us. And place that in the sharps container. Start by cleaning the table. We want to make sure we wipe down our heating pad as well that our patient was on. You want to make sure you're wiping below your heating pad. You really want to make sure you're getting just any of your biological debris off the table from your procedure. And we're wiping down any lateral surfaces in here. So we wipe down our instrument tray. We're wiping down our counters. And then we remove our trash bags. This is our surgical waste from our waste bin. If we had any hazardous materials or anything that we might consider zoonotic, we would double bag this and take straight outside. And then lastly, we also wipe down. We are cleaning everything with rescue also, so we wipe down our equipment table as well and the equipment itself. We wipe down with a little bit of alcohol. So we kind of just do a good wipe down of our ECG leads. SpO2 as well. And then wipe down our equipment table. And then lastly, we would clean the floor as well. So we have a designated mop for our surgery area. So we'll go around the floor with this and we try to clean kind of a 3 to 4 foot radius of our surgical field. We also make sure that we're wiping our light fixtures where the doctor or the surgery technicians have touched. You want to wipe the whole outside handles and outside and around the light itself as well. And then lastly, we can remove the rope that we use to secure the patient. If those have gotten dirty as well, we place these in the laundry and wash those also. So after the procedure, we place our instruments in our sink bin so they can kind of pre-soak, and then we add some of our instrument cleaner to our sink. clean, you want to make sure you're opening your instruments, getting between the blades, between the ratchets, under the box locks, because you don't want biological debris to build up in there. So we just kind of do a general scrub. You want to use a softer bristle brush. You don't want to use a wire brush on your instruments. And then we can rinse in some distilled water. Cotton bowl here. And then we place our instruments in the ultrasonic cleaner. So after we scrubbed all our instruments, we place them in the ultrasonic cleaner and start that for 10 minutes. And the ultrasonic cleaner essentially is using sound and vibration to make bubbles that clean the debris off of the instrument. So after the full cycle in the ultrasonic cleaner, we do a little bit of a rinse with some cool water just to cool them down so we don't harm ourselves taking the instruments out. And then we take them out. And we lay them out to dry. You want to make sure they're fully open when they're laid out. That way the instruments can fully dry, laid out properly. And then we do a little bit of a spray on our instruments with a instrument lubricant. And now we can allow our instruments to sit and dry, and then we will wrap them up in packs. So for packing your surgical instruments, once they've been cleaned, you're going to put them in your pack. You've got gauze already, and there's also an indicator strip that's inside the pack, so that we can make sure once the pack's open that it's sterilized thoroughly. So place our instruments on top of there. And they all go in the center. Place your drape on top. And then to fold, you start with the flap closest to you. You fold that up and keep a flap down. So that's what you're going to be pulling to open the pack. Do your sides next. And then the top last comes over and it tucks into your other flaps, but you want to make sure you still have a tab at the top. To pull to open your pack. So that's your inner wrap. We do a double wrap. So I'm going to do the same thing with our outer wrap. I'm going to fold up and keep a flap. 5. And then the last flap again folds up, folds into those that you've already wrapped, and keep a tab out so you can pull that and open your pack. So that's an envelope fold. So after folding, you apply your sterile indicator tape to the pack. And this, once it goes through the autoclave, is going to change color to indicate that everything is sterilized completely. So I'll show that in a little bit, and then you can write your type of pack on here. So this is a small pack. Today's date. and then my initials on the pack, and then we can put it in the autoclave. To wrap a gown, you're going to start by laying it with the outer surface up, so the outside up in your pack, and then kind of straighten your sleeves and your cuffs. You're going to fold the near side in. Then fold your outer side in. Straighten. Then fold your gown in half. And then fold up in an accordion fashion. And as you fold, you want to make sure your necktie is at the top and easy to grab so the doctor can pull and slide their arms in the sleeves. So then you're going to place an indicator strip in the center of your fold. And then you can do your first inner wrap. So you place your gown in the center. You're going to fold the corner closest to you up first and keep that little lip there. Same with the sides. Keep an extra fold there. And then the very last top gets folded into those. Gets tucked into those, but you keep a little tab out so that you can pull that and open your gown. You're going to place your towel on top of that, and then you can do your outer wrap. So this is wrapped again the same way. Your first tab gets pulled up. Keep your lip there. Do the side. And then the top comes around, tucks in. Tucks into those folds, but keep that tab out at the top. We can now put some sterile indicator tape on the outside, and then place our pack into the autoclave. So once our gown pack is wrapped, we've got our tab there that we can pull and open the pack. We place our sterile indicator strip on the outside. We write that this is a gown, today's date, and our initials, and then can place in the autoclave to sterilize. So this is the autoclave. The autoclave works by electrically heating water to create steam, and then the steam pushes all the air out of the autoclave so that then the temperature and pressure builds up to the appropriate setting, and then the steam under pressure is what kills microorganisms. So to demonstrate, we're going to put our packs in the autoclave. You want to make sure that they are side by side. You're not cramming packs in there. You're not putting packs on top of each other or anything like that. Close that in there. If we needed more distilled water, you could put that in. So then we turn our knob to fill water. So we watch our water come up just above this little dip in the autoclave. And then we turn to sterilize. And shut. So for our instruments, depending on how long you're autoclaving for, it's going to depend on your instruments and your practice. Here, we keep our temperature at 273, and we turn our timer to 40 minutes. For our book of good general sterilization, it mentions in there is to use 250 degrees with 15 psi for 13 minutes. So that would be a proper setting for sterilization of the autoclave. So after the autoclave runs its full cycle, we then turn to dry. This decreases the pressure within the autoclave and allows us to open the door. You always want to open the door after it's run so that condensation doesn't build up in there and that moisture is allowed to evaporate. For maintenance on the autoclave, we have something called Chamber Bright. Any autoclave should have this. It's a cleaner that we run through the machine, run on a full cycle for 45 minutes. It cleans the machine, and then we wipe it out, make sure it's looking good and clean, no debris left in there, and then run again once more on another 45-minute cycle, and we do that until the cleaner is completely out of the autoclave system. So that's an important way to make sure you're maintaining the autoclave. You want to make sure after it runs, each time you're opening the door, and you want to make sure you're draining the water out of the machine each cycle and adding fresh distilled water each cycle, which gets added at this port at the top here. And lastly, for maintenance on the autoclave, you can also do spore testing, which has a strip that we can run through the cycle and then send this off to the company to make sure that the autoclave is running properly and nothing needs to be replaced. So then we can remove our packs.
Margie, you're a Margie.
And we know that our packs have been sterilized because of our strips that we placed on the outside. They turn brown, so we know the color change indicates that those packs are sterile. There's also an indicator strip on the inside of the pack as well when it's open, so we can be double sure that that pack is fully sterilized. So we're going to be demonstrating doing a suture removal. When you have sutures in, what you're going to be looking for, whether it's ready to be removed, is that the skin has completely closed. There's no redness, draining, or swelling. Any of those would be indicative that maybe it's not healing well and you would want to go to your doctor and see what your next step should be. So to remove the sutures, you're going to grab hold of the knot. You can use forceps if you want, just kind of immobilize that. You're going to put the curved blade under that knot, under the suture, between the suture and the skin. Cut and pull at the same time in one swift motion. Good girl. Again, I'm immobilizing that knot, cutting and pulling at the same time. And then we take a look. It looks good. The site has closed. There's no drainage, no swelling, or anything that indicates infection or anything.